Sure.
Okay. So first of all, good evening, everybody, and welcome to the next installment of our weekly webinar, which we've all moved to during the COVID-19 outbreak, and which has become a weekly feature, and I think well appreciated by most. I'm delighted tonight we're going to focus on a very, very important issue, and I think something we've all been reflecting on for the past number of weeks. The title is Resilience Realistic During the COVID-19 Outbreak. And to take us through that particular question, and I'm sure we all have different views and opinions and experiences, I guess, of those that question during the last number of weeks. We're going to be joined by Professor Eva Doherty, and Eva is a clinical psychologist in the Department of Surgical Affairs in RCSI and is the director of the Human Factors Programme and well known to many people here and heavily involved with the HSE and the communications programmes within the HSE over the past number of years, and has published a lot on these areas. And of course, also joined by Professor Peter Gillen, who's also probably well known to many people here tuned in tonight, and is also involved with our Human Factors Programme, teaching on our medical Masters in Surgical Science and Practice, also heavily involved with the HSE side of things, and is going to give us a very interesting perspective on the impact of COVID-19 on the surgical community. And it's interesting, we've probably spent the last number of weeks talking about surgical practice and various issues and like that, but this is probably more focused on surgeon, the individual, and I guess the impact it's having at a very human level on people. So it'll be very interesting to hear that discussion tonight. But as always, we start the webinar with an introduction and an update from our president, Mr. Ken Mealy, who will give us, I guess, an update on what's going on with the department, HSE, and our interactions with those organisations, as well as maybe where we're heading for as we see more and more activity, surgical activity coming back into our hospitals, and the patients with all the other unmet need over the past number of weeks starting to emerge and will need to be cared for. So without any further delay, I'll hand over to our president, Mr. Ken Mealy.
Kieran, thank you very much, and you're all very welcome to this week's webinar. I think this is our 8th in a series, and as always, we welcome your feedback on any of the topics that we're discussing and any other topics that you may feel is appropriate that we address. The emphasis is tonight, as you've just heard, is on the human factors issues in relation to resilience. But resilience really needs to look at the broader picture, and we've attempted to do that over the last number of weeks, because no matter how resilient we can make any one individual, if the process that we're involved in getting back to normal activities is not resilient itself, we're going to build up difficulties for many of our colleagues around the country for the months and the years to come. The previous webinars have emphasized work that we're doing with the Department of Health and the HSE and our sister colleges, the colleges of physicians, anesthesiologists, and our GP colleagues, in trying to define what the new normal would look like. And it's becoming clearer, I think, to many of us that the model of care for return to practice is going to be significantly different than what it has been in previous months and years. We know that many aspects of our care will need to change. We'll need more comprehensive governance structures. I think there will be an onus for all of us surgeons that if we are consenting patients for surgery, for instance, we need to know the risk profile of our hospitals. What is the chance of any of our patients becoming COVID positive? And if they do so, in association with major surgery in particular, what is the mortality associated with that? And those figures are starting to appear around the world. So each of us have a responsibility to be able to impart those figures with local knowledge to patients undergoing surgery. as you heard last week, we see patients we'll be seeing patients in a different format. For many of us, it may be that for many conditions, the first time we'll meet our patients in person will be when we carry out a procedure or an operation, because many of our patients we may see in virtual clinics, and clearly we need to pay some attention as to how we can do that safely. You may hear some of that tonight. The nuances as to how we communicate with individuals is very different to when we're seeing patients face to face. The pre-assessment process likewise might become virtual, and if that is online, again, we need more attention paid to the times when we do see patients on the day of surgery or procedures, for instance, and we need to allocate more time for our nurse colleagues to admit patients and our doctors and anaesthetists to see patients on those days. So efficiency issues will come into play here, and we need to understand that when we're planning lists. We've repeatedly emphasized patient and staff safety. The care pathways for the future are likely to include COVID testing for all patients undergoing surgical procedures and aerosol generating procedures. Some of those care pathways may also include that staff need to be tested so that we can be assured that we are safe to work with, and the public can be safe that if they do come into hospital, they're not going to get COVID infections from the staff. And we also then need to be aware that there are false negatives, there are sensitivity, specificity issues with these tests, and we need to be aware of what they are in our own environment. The care pathways themselves need to be worked out. We need to be able to demonstrate to patients that we can offer them a COVID-free care pathway. And if we can't, well, then we need to evaluate the risks specific for those procedures in a situation where patients may develop COVID infections. And this is where the private hospitals come in, because certainly the Department of Health in the past, as you know, have taken over the private sector and advocated that we use the private sector. That hasn't really worked out very well for all sorts of different reasons. But if that relationship continues, it may be that a higher volume of low acuity work will be carried out in the private sector. And we need to work through and think how we could engage with that, facilitating much of the public care taking place in the private sector. And how do we bring our trainees with us under those circumstances? And these are all issues for the future, but I would ask you to start thinking about these things, because local needs will dictate variations in some of the issues that I've just discussed. And the final issue then I would ask people to consider would be the technology that we use. Initially, there were guidelines indicating that laparoscopic surgery, for instance, may be problematic, and we still don't know whether the risk of infection with laparoscopy and air plume ejection from the abdominal or the thoracic cavity, particularly if there are air leaks in the thorax, whether they're problematic. And we need to work out those issues. We need to understand the technology of the ventilation systems that are in our operating theatres, how many air changes we need to sterilize the air, have we negative pressure theatres. And there's an onus on each surgeon to understand those conditions for their own set of circumstances. And I think until such time as we work through each of those issues and define safe care pathways for our patients and identifying safety issues for not only our patients but our staff, until we work through those issues, I don't think we will have a resilient system. Now that's all on top of resilience in each individual, and that brings me then back to Eva Doherty and Peter Gillen tonight. I'm delighted that they're going to join us tonight. They have huge experience in communication skills, within team working and leadership, but also communication with our patients. So I look forward to their question and answer session and perhaps joining the conversation later on. So back to you, Kieran.
Thanks, Ken. As always, just to remind everybody, if you could just ensure that your mic is muted, to be great, and perhaps on your video then as well, because often that speeds up and has a better quality in delivery. Also remind people, if you want to send in questions or queries that as you hear the discussions and indeed what you've heard from the president there now, use the chat function on Microsoft Teams. We'll then put those questions to the panel later and see if we can answer them. We've had a number of questions come in earlier on during the week, and we'll try and get to those then as well if we have time. So slightly different format tonight, I understand. It's going to be more like listening to two people discussing this issue, but two people who are very well informed and know how to maybe ask and pull out the right questions. So it won't be the usual format of a presentation and so on. We have a few slides to help structure the conversation. But Eva and Peter are going to take it away now and address this issue as best we can and see what we all feel about that. And again, as I said, please send in your queries and questions, and we'll get to those at the end of the session. So I hand over now to Eva and Peter. So Peter, you need to unmute your mic if you can.
Your pardon, sorry.
Okay.
Yeah, thanks. Welcome everybody, and I'm delighted to be here this evening with you. I'm really looking forward to this. It's a slightly different format, as Kieran just mentioned. We're going to have a chat for about 25-30 minutes, and then we're going to take some questions, and we hope to wrap it up well inside the time. I'm delighted that Eva's with me here this evening. We're going to maybe try and tease out some of the issues that are very relevant at the moment. I'm delighted that, Mr. President, you gave us a terrific where we are now and where we could be in the short little while format talk to begin with, and that set the mood. So maybe I'll put Eva on the spot straight away, and I'm going to ask her, what is the answer to the question that we just posed? Is resilience realistic in the current climate?
Thanks, Peter, and hi to everybody. And when you and I were planning this, Peter, we decided we would try and be a bit provocative and a bit controversial in our choice of our title for our discussion this evening, because it's been my experience that when clinicians find themselves in really, really difficult work situations, they rightly get very frustrated with the implication that they're supposed to be resilient. And this really does fit with, in fact, psychological models and our understanding of the term resilience. And in fact, psychologists have moved on from considering resilience as an individual magical trait that people, either do or don't have. And we now speak about resilient systems. And Ken, you're right up to date there when you talked about resilient systems earlier on. And so, we now understand that resilience, if you like, is all to do with multi-factors going on at multi levels in systems. And that the most resilient systems are the ones who employ good, effective problem-solving skills, who have strategies for self-regulation, who, maintain a sense of hope, who are motivated towards, experiencing what we call mastery. We'll come back to that. So this is the idea of struggling but overcoming. And what comes up a lot in all of the research that's been done in this whole area is the importance of hanging on to your purpose and your meaning and the whole reason why you got into this kind of thing in the first place. Maintain your relationships, they're absolutely crucial, and hold on to the routines and the rituals. So the bottom line about resilience really is that it is best understood in terms of systems rather than in terms of individuals.
Okay, so what I've been doing is I've been taking soundings really from lots of different surgeons around the country coming up to this evening. So I've kind of concentrated on people from hospitals where they've been impacted by COVID. So mainly in Dublin, say the Mater, James's, Beaumont, also Galway, and a level 3 hospital like Drogheda. And it's been remarkably consistent what people have been saying to me. So what surgeons are saying, Eva, is that they feel at the moment that they have a loss of control. They're worried also about an uncertain future, and they're also somewhat confused with the guidelines, as the president said, changing, 2 weeks in cocooning, testing at 72, testing again at 24. No, that's different to last week, and so on. So there's a sense that surgeons like to be busy, they like to be in control, and at the moment they're feeling, I don't have much to do, I'm not getting that sense of fulfillment that I would normally get from being a surgeon. So what do you think distinguishes people who do well in this kind of environment?
Okay, thanks, Peter. And before I just move on to that, one thing I forgot to say about resilience is there's a nice word that we use often in place of resilience, which nicely portrays, I think, what resilience really is, which is bounce back ability. And so we can only know whether that's going to happen after the event, when the crisis is over. And I think that's just a point I forgot to say about resilience. Moving on to your question then about, what do we know about what individuals, survive? Because that's really what it is. It's about survival. It's about being good enough. It's not about, being, achieving, the greatness maybe that or, the things that people might have felt able to aspire to previously. But what we know from studies of large studies of individuals who had to go through major disruption, like what's happening now, is one of the most important things was if they were able to maintain their sense of the big picture, and if they were able to continue to commit themselves to quality work, and also to keep on with their personal activities that are important to them and their family. So we call that commitment. Erica, you might want to bring up the slide here at this point. So commitment is a hugely important factor. The second one is the whole issue of control, because as you say, Peter, people are feeling a terrible sense of lack of control, and our brains are, are always targeted towards maintaining a sense of control. We don't like uncertainty, and our brains are really good at filling in the gaps when we're not sure about something, and explaining things to ourselves when explanations are absent. And so this is totally anti being a human being, if you like. However, the real challenge is that those individuals who do the best in these kinds of really difficult situations are the ones who can, if you like, let go control. And that might seem counterintuitive, but people who can, another phrase that people often use is, being able to surf the wave and go with it. And that can feel like, the scariest thing to do, because you're venturing into a territory and the sands are shifting all the time. You really don't know what's ahead. It's like, we're all feeling our way along a tunnel in the dark at the moment, and we don't know what's ahead of us. However, if we can try to be flexible and let go, then we will fare better. And the other thing that's come out in a lot of the research is it has shown that people who see change as a stepping stone, as an opportunity, rather than as a stumbling block, they seem to fare better as well.
Okay, so I'm going to come back to that maybe about change later, but as I was listening to you there, I was just hearing in my head what several people have said to me last week about how frustrated they are in their job at the moment, the length of time cases are taking to be done. People don't feel in control, as I said. They feel they're being controlled both by the system and also by the anaesthetist, which never goes down terribly well. And so cases are taking a long time. Things are very, very fluid. And it's very difficult for people to feel that they're getting the same buzz from being a surgeon from it. So that goes really to what you were saying. It's interesting as well that I asked people about their own personal fear of the virus, and not just of catching it themselves, but also perhaps of bringing it home to loved ones or parents or cohabitants and so on. And university people are now saying to me they're less worried now than they were 9 weeks ago. We seem to have avoided, thank goodness, the Bergamo and the Madrid kind of situation. And because of that, people are less worried. Do you think that that's going to lead to clearer thinking on behalf of surgeons, or a more perhaps reckless idea that we're over the worst, let's try and get back to what we were doing before?
Yeah, and I think I was watching the webinar last week, and Tony Cox made a great point where he put up that slide and said, I just want my old job back, and which was very impactful on me. And I've come across a couple of other quotes that I think maybe reflects what you're saying. Apparently, after the 1916 Rising, Yeats said, "As yet, one knows nothing of the future, except that it must be very unlike the past." And I think this is what we're struggling with, that we really don't know, where we're heading. And, if you think about what happened in 9/11, travel has never been the same since, and probably will never be again. And the reality probably is that, healthcare is heading, to be unrecognizable, to what it was. And that's going to take an awful lot of getting used to. And just to keep on quoting Yeats, I went off and looked it up. I'm a bit like Leah Varadkar on the Late Late Show. I had to write it down. But he said, "Now and in time to be, wherever green is worn, are changed utterly, and a terrible beauty is born." And I think that reflects where we are. And this is really challenging to be in this time of flux when nothing is predictable anymore and nothing is the same. And as you say, everything, the way practice in the hospitals is just so different.
Yeah. Just in case anybody tuned in there a moment ago, this isn't a webinar on English literature, by the way. It's talking about resilience in healthcare. So I like that analogy about a terrible beauty is born, because it did come out when I was speaking to people that they did see or we're beginning to see opportunities to change here. And, some people were more optimistic than others, in fairness, but most people thought that it's never going to go back to what it was, but that could be a good thing in some areas. So, for example, telemedicine, and again, the president alluded to this, virtual assessment of people is probably going to be here to stay. And again, I'm concerned, and from the college's point of view, that we need a little bit of upskilling there. People are saying, "Oh yeah, I'll try that." I don't think that's just the correct way to do things. But there could also be different pathways, as again, the president alluded to, like COVID and non-COVID hospitals, for example, for work to be done. So I suppose really what we would like is an adaptability button that surgeons could maybe switch on at the moment. Isn't that correct?
Yeah, and as I say, change, being able to see change as an opportunity, being able to let go control and, ride with the wave, and being able to stay committed to the big picture, and to keep reinforcing yourself in your mind, the whole meaning of your vocation, because I think surgery is, the reasons why you picked it, they're still there. And keep remembering that, and it's down to patient care at the end of the day, isn't it?
Absolutely. And I do want to mention, because then the president alluded to the private hospital sector, and there's a lot of full-time private practice consultants out there feeling that they've been treated very unfairly. And again, unfairness is a pretty nasty thing for your psyche, isn't that right?
Yeah, so there's absolutely, it's one of the toxic factors, and we've written them out for you in a couple of slides, Erica, if you want to bring them up now. It's one of the kinds of systems that trigger burnout in us, have particular identifiable factors. So Erica, if you want to click on to the next slide, we'll be able to see what they are. So workload can be considered a toxic factor. It's not the most important one, funny enough. And of course, if we reflect on that, there's times when we have absolutely crazy days, but we have a great sense of achievement about that. But workload is definitely still in there, and I know everybody's workload is changing currently. Another toxic factor is this idea, again, here we go again, of control and autonomy. And it's whether you feel like you have a circle of control around you that you can control. A lot of people have written about this. Covey, who's written The 7 Habits of Successful People, talks about the idea of having our own circle of control. And if we focus on that, it gets bigger and bigger and bigger, if you like, and we feel much more satisfied. The third factor is the whole idea of, I can't actually see it with my thing there, sorry, is the need for us to have a sense of reward and recognition. So, you know, we will do anything if we feel that we're getting, our efforts are being recognized. It's organizational psychologists well know that people don't leave their jobs, they leave their bosses. And so I really do think in this time of terrible stress that we keep on recognizing, and I have a feeling that that is going on in hospitals, that people are really gluing together and coming together, and there's a good sense of camaraderie for the most part. I'm sure it's not 100%, but you know, having a sense of recognition and reward, or not having it, is a toxic factor and leads to burnout. And then the next 3 factors, Erica, is this sense of community and trust, which sounds a little bit touchy-feely, but really what it means is, do you feel like you're working in an environment where everybody has everybody's back, and you know, that you don't feel that you're going to be landed in something? And I wonder, actually, I think people might feel that they are going to be landed a bit, you know, if we get a wave of, you know, of non-COVID patients in the months ahead, you know, are people concerned that, you know, that could be an issue? And then we have this toxic factor, fairness or unfairness, which is really critical. And again, people will put up with all kinds of adversity and difficulty, but if they think things are unfair and being doled out unequally, then that has been shown to lead to burnout. And finally, the other factor that's really important is whether or not there is hypocrisy in the system. You know, are people matching what they say with what they do? And I'm actually not sure. People might have interesting comments on that. You know, don't know what the perception at the moment is out there in healthcare. You know, is what is being presented in the media, is that actually matched with what's on the what's going on in reality? You might have something to say about that, Peter.
Yeah, and you know, just to reiterate what you were saying there about the second wave, or the wave of non-COVID patients, I think what surgeons have been saying to me is that they're concerned about having to re-triage urgent waiting lists, because if the capacity is very reduced, then they're going to have to cherry pick the most urgent. But that puts a lot of stress on people, because you don't want to miss something. And if you get a referral that says vague abdominal pain that turns out to be a pancreatic cancer in 6 months' time, are people going to be medical legally, you know, exposed over decisions like that made in a crisis? And that's a real issue. So again, people have to have faith in their organization that they're going to have their back. And I think that those points really hit home to me as a surgeon, for definite. There's another group that I don't want to forget, because they've contacted me as well about their concerns, and that's trainees. So, and I know that I sat through the ACIT, the Association of Surgeons in Training webinar last night, and they were addressing the same concerns in the UK about, you know, the deficit for trainees this year. They're going to miss out on their e-logbook. Surgeons are telling me that through no fault of anybody's, because it takes so long to put somebody asleep and you want to limit the time exposure face-to-face in the theatre, they're doing the cases themselves in order to expedite the work. And so trainees are kind of losing out. And again, as a college, we have a lot to do with supporting people like that. But from a psychological point of view, have you any message for trainees?
So again, it does come back to the whole unfairness of it. Like, this is not fair, and let's just be upfront about that. And you know, rather than trying to cover that up, I'm not going to speak for what surgical training in the college is going to do for trainees. I know trainees are incredibly important to them, and they're, it's what we do. There are the skeleton. What would you say? The skeleton in the whole body, if you like, and so people are going to strive to make sure that as much as possible, things can be compensated for. But undoubtedly, this is all, unknown territory. And, it's going to be very hard, I think, for trainees to be allowed to do operations, because I know I've heard on previous webinars, trainers talking about how, if they get to get in to do some of these procedures, they're not going to have the time, to support a trainee to do them. They're going to have to do them themselves. So we're really going to have to think outside the box, I think. But I think the first important thing is to acknowledge that this is unknown territory, to acknowledge that it's not fair.
And I just want to follow that up maybe about some practical tips you might have for people that perhaps are a little bit struggling, maybe trainees, maybe surgeons, maybe anyone in healthcare at the moment. We're hearing or reading that, for example, supermarkets are selling a lot more alcohol than they've ever done. And there's a sort of, what people are terming the clink of shame as people trip off to the bottle banks, So there's always the great danger, isn't there, that people start to rely on substances like alcohol and other stimulants. Do you have a take on that?
Well, what I'm going to say is there's got to be a balance here. This is not about, being 100% super duper. However, there has to be a balance. And if we plunge into, too much self-indulgence with things like alcohol or, sugary food or whatever, we're going to pay the price. There's an interesting link between alcohol intake and subsequent post-traumatic stress following a crisis. So do be aware, that if you do use alcohol, as too much of a crutch, you could be setting yourself up for, quite a traumatic reaction down the road. So it is a risk factor. So I think there's a balance there. I do know that, any of the studies done on the personalities of people who go into medicine, they're highly conscientious people. And so it's very easy for them to criticize themselves and to give themselves a hard time. So I'm going to say there's a balance, put it that way. And in terms of kind of practical things, I mean, in the training days that I do with trainees on managing stress, what I find they like the most in terms of all the different kinds of strategies that we go through, they really like the idea of keeping a kind of an eye on your breathing, because the first thing that's going to go askew is our breathing when we're under threat. And so just keep an eye on your breathing. Make sure you're taking at least 20 deep breaths every day. It's a really good thing to do as well if you've just been in a really terrible situation and you've now got to go into another one. And just keep doing a kind of a body scan, make sure that you're not going around with really tense shoulders. The other thing that I know the trainees like, and this is particularly good if you're feeling very frustrated, and maybe if you're feeling very frustrated with certain colleagues, is to sit down and write them a letter and say exactly to them what you would not say publicly, and then keep it or throw it out, or maybe do it in your notes in your phone. Definitely don't do it in your email in case you hit send by mistake. And another really good strategy, again, that I know trainees like is the idea of 3 good things. And this is, you only have to do it for 14 days. And you and I, Peter, have done this on Twitter from the May the 1st to May 14th. So we're going to be blessed now with a years of improved mood as a result. And laugh not, there's really good evidence about this. In fact, the trend is that it's as good as, if not better, as antidepressant medication for people who have mild to moderate mood problems. But it's about recognizing what are the really 3 good things that happened to me today. And it could be as much as simple as you had a nice cappuccino. And you do that within 2 hours before you go asleep. And I would suggest that people do it on a WhatsApp group, either with their family or with their team. It would be really nice for team morale to do that just for 14 days. Because what it does is it makes us start to notice positive things that happen. There's a nice saying that goes, negative helps us to survive, but not to thrive. And thriving comes from, focusing on the good things that happen to us. Apparently, a wise Vietnamese monk said, we are rarely thankful for the non-headache. We don't go around thinking, oh, thank God I don't have a headache today. But we will, we focus in on the negative and we brood on that. So 3 good things is a great way. And another one is, and I'll stop here, but is the 90-10 rule, which, 10% is what happens to me and 90% is how I respond in terms of how I do.
Okay, lots of things to think about there. Maybe, the next thing I wanted to talk about a little bit about is that what surgeons are saying to me is that they're bemoaning the loss of the team concept. That, years ago we had a structure where we had a consultant, an SR, a Reg, SHO, 2 interns, and they hung out together. Everything was done in a team. You got to know the whole team. You relied on the whole team. EWTD started to fracture that. Then you were post-call or pre-call, and the ward round was with somebody who was going home or gone. So that was difficult. But now juniors are saying, well, I'm being redeployed to ED because there's no elective work happening, or I have to go for retraining to ICU and so on. So I've been hearing in some hospitals where, a particular consultant has taken on a leadership role and getting together all the juniors on a WhatsApp group and by email or WhatsApp and just keeping in touch. And I thought that was a lovely touch. And a kind of a nice example of leadership. And maybe you might expand on that and that whole concept of psychological safety, because we hear so much about that now.
So I think the challenge for leaders here is to think of clever ways of communicating with their teams. And that the idea there that you said about WhatsApp communication is super. And it's just, tuning in with people and saying, how are you? How are you doing? What's going on? What sort of day are you having? And the idea of maybe having these kind of virtual huddles, a couple of, maybe once a day or even once a week, whatever you can manage is absolutely excellent and keeps a sense of team cohesion. Something else I think that's coming down the track at us very much, and it's going to have a huge relationship with a lot of the cultural changes that I know we're going to speak about in a sec, Peter, but just to talk about it now is this whole idea of psychological safety. And this, Amy Edmondson is the person who's most associated and credited with this term. And it's defined as the belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. It's been shown in research to be highly predictive of team performance. Google you can Google this, have a project that they call the Aristotle Project, and out of all the possible characteristics of their employees, the most predictive of best team performance was psychological safety. And so for leaders, and I'm gathering that a lot of our audience tonight are trainers and are, maybe reflecting on their role as leaders now of their teams during this really tough time, they might might ask the question, well, how do I create a culture of psychological safety in my team? Like, how do you actually do that? And Amy Edmondson has identified 3 main ways, and she has some fabulous YouTube videos that you can check out. And the first way that leaders can encourage this is to always see performance as a learning curve. And nothing is ever known. We're all learning, and never more so than now. And so when things go wrong, it's like, okay, so this is a learning curve. What can we learn about this? Let's try and sort it out so that, we don't make this mistake again. And the second idea is the idea of the leader as a model of mastery. And we know from psychological research that models who initially struggle but master are incredibly impactful on for observers. So, I think sometimes leaders might feel under pressure that they can never show any signs of fallibility or struggling, or, they have to be all knowing and all capable. That's not actually the case. As long as you demonstrate that you have the resources, or you know where to go and find them, you have ways of solving the problem, that is very impactful. And then the third way that a leader can trigger psychological safety is this idea of having intellectual curiosity for everything. So tell me what you think. I'm really interested to hear about why what happened, and to engage in those conversations with people, to try and have as she would say, a sense of learning and continuous mastery.
Okay, so that's really helpful. And just as you were speaking there, I was thinking about Leo and his crib sheet on the Late Late, and how everybody really warmed to him, that he was able to sort of say, oh, hang on a sec, I'm not really sure, I don't want to make a mistake, let me check my notes. I thought that was a lovely example of what you were just saying there about mastery. So the last topic that I just want to cover is really about what we mentioned there in passing, culture. And I was very interested to read Atul Gawande's essay just recently about this, where he's talking about calling in and calling out. And the calling in is to call in when you're ill. Even if you have like a sniffle at the moment, it could be the beginning of COVID. So surgeons traditionally, go to work when, they've got half a lung functioning, but they're still going to try and do the list or whatever. So we're not great at calling ourselves ill and I'm going to stay at home. So that's a culture change, and I want to ask you about that. And finally, perhaps even more controversial, what he talks about is calling out. So calling out people or behaviors that one would see that are not acceptable. So somebody taking their mask down in a healthcare environment to speak to somebody else. How will surgeons or professors of surgery or whatever react if a nurse manager or student nurse comes up and says, excuse me, you shouldn't do that. That's not good technique. That's not what we practice. So calling in and calling out, what do you feel about those?
I think this is going to be a challenge, because we are, I have a sense that this is a real right turnabout face, if that's such a phrase, because I'm not so sure that there is a culture of psychological safety in healthcare environments, and I think there could be a bit of pushback to people, saying to each other, whoa, stay 2 meters away from me, or you shouldn't be pulling your mask, down under your nose, or things like hygiene and hand washing and all of that. I think we're really gonna have to embrace that explicitly if we're going to make it work. And if we don't, we're looking at a very, very slow return to, there isn't going to be, the old normal. It's a new normal, isn't it? But how are we going to get back to any kind of semblance of anything unless we embrace the whole idea of this psychological safety and of, being able to give people constructive feedback, because we're all human, you know what I mean? I mean, PPE is not nice to wear, and people get boiling hot and sweaty, and it's totally understandable, and why somebody might pull their mask down on their face, and so I think that's going to be hard.
Okay. All right, well, they're kind of some of the topics that I thought we might cover. And Kieran, we might go back to you if you don't mind, and perhaps hopefully some questions have come in that Eva might be able to address.
So thanks, Peter and Eva. That was very interesting to hear all the various aspects you were going through there. And Peter, thanks for doing your bit of research, I think, in fairness, and trying to get a feel for what's affecting our surgical community out there at the moment. So lots of issues and topics there to sort of delve into if we want. But I guess, you know, my experience of dealing with healthcare professionals and surgeons and nurses and so on is that they really get an awful lot of their energy from working on their patients, and the feedback they get when they're dealing with their patients and their families and so on. And here we are now, everyone's going to be gowned up. You can basically barely see, you know, between the nose and the forehead is all you can deal with people. Being able to interact in the usual way is not there. What sort of approaches do you think we need to do to try and maybe re-engage that empathy and connection with patients?
So I actually made a video on that. If people are interested, there's a short little brief 5-minute video about how to, you know, communicate and manage patients' distress. And I talk a little bit about PPE, and that's in the resources section of this same COVID section on the RCSI webpage. I mean, the bottom line, Kieran, is I don't think there's no magic sort of solution that's going to totally unravel things here. I mean, I love what people have done about putting, you know, photographs of their faces on their, you know, on their gowns. I've seen on Twitter where people actually have sheets of stickers. It's probably American, you know, of their faces. So every time they change their gowns, they can slap on a sticker of their face. I think we're going to have to be very aware of our eyes, because, you know, that's all our patients are going to be able to see. So if you use your eyes to, you know, an exaggerated effect, I think, to try and communicate the emotion that you're wanting to convey, you're going to have to really pay attention to your tone of voice, because that's all you have. Because, you know, other cues, other body language cues are muffled because you're wearing all the PPE. And then when you think again that a lot of the communication going forward is going to be in the form of a phone call or a video consultation, and Peter and I, in the national program with Winnie Ryan and the HSE, we've come up with some online training on that. There's one already up there on telephone conversations, and there's another one almost ready on video consultations. And Peter's done a huge amount of work on that. And there again, all the normal cues are gone also. And so, yeah, it's going to be about, you know, not carrying on, you know, the old ways. We're going to have to generate new ways.
It's interesting when you mentioned the new ways and old ways. You know, you hear the sayings like it takes 3 weeks to develop a good habit. It took me a lot shorter to develop a very bad eating habit over the last few weeks, I have to say. But all joking aside, though, I think people, to develop new habits, they haven't actually been you know, active and immersed in the new ways we have to work. And we're talking about how to redesign models of care and so on. So while everyone thinks that we've been at this now for 10 or 12 weeks, and so, you know, changes are going to get in there, I actually not sure we're anywhere near understanding what the change agenda really is shaping like, and how people may, I think that's adding to the uncertainty. So, you know, are we finding there's waves of people who are more used to the change because they're at the front line of the COVID piece, the rest are catching up, and therefore that's creating its own tensions when some say we've changed, others are not there. Is that something you think is out there?
Yeah, I mean, absolutely. Well, and I'm a little bit removed because I'm not training the trainees at the moment. So that's why we thought it'd be a good idea if Peter went out and did a bit of on the ground research to try and find out what's going on. But from what I've gleaned, I think it's as you say, we don't know what the new normal exactly is going to be, and it's not going to be even the way it is now, because, you know, because this is not normal healthcare, what's going on at the moment in any kind of a way. And there's a whole load of, you know, there's a huge cohort of patients out there who are not even coming in, getting as far as the hospitals, and they're, you know, must be heading to the hospitals at some point, and how are they all going to be managed? And so it's like we're feeling our way in a dark tunnel and we don't know where we're going.
Yeah, and Peter, just, you know, as a surgeon, like that issue that you were, you know, feeling the way things are changing rapidly, you name it, like when things are that, I guess, chaotic to a certain extent, you got to get back to basics. You got to go back to fundamental values. So, like, what are the key maybe values or anchor points that the surgeons and surgical trainees should try and focus on, as the detail is changing all the time, but there are some things that never change? What would they be?
Well, you know, at the core of all of this is going to be a patient-doctor relationship. It might look different. It might be dressed up differently. No pun intended. I mean that, dressed up differently, but it's still the same core doctor-patient relationship. You still got to maintain the sense of connection. You've still got to encourage and foster a sense of trust. So the patients have to trust us. And as the president said at the start of this, so much of this now is going to be keeping yourself informed. This is a rapidly changing game. And, you know, even the new COVID surge paper that's out at the moment, showing that the mortality for even elective procedures is so much higher than people thought previously. So risk stratification, again, as Ken alluded to, is so important. We have to keep really up to date in order to give proper information to patients. If we're well informed, and I think the college has to be complimented here, and you in particular with these webinars, they're keeping people informed as what's happening. By doing so, we're able to give people better decision-making tools. So the National Care Pathways, the programs are all working very hard in order to stratify people's thinking. And if we're all on the one page like that, there'll be a collective responsibility in providing care. And I think that, you know, the college is to be commended for that. If we feel that we're not doing anything outlying, if we're doing what everybody else is doing, and if we're all doing what we've been told by a guidance organization that we're doing, you get that sense of collective safety. And I think that's where that's going to help us. And we can go to patients and say, normally we'd take your appendix out, but your CT scan shows that it's not perforated, and you'll do just as well with antibiotics at the moment, because if you pick up COVID in this hospital, you could have a 20% chance of dying after a simple procedure. And so those kind of conversations are going to be so different to what we had in the past, but they have to be informed. And I think that's the key to it, information.
And you're right. And with that information changing fast, Eva, how do you envisage our human factors program, which is, you know, a huge component of the surgical training curriculum for all of our trainees going through? We have the new curriculum, you know, due to come out next year, which is going to focus on the competencies in practice, and a lot of focus on professionalism and how that should be looked at. So what sort of changes do you envisage we need to be incorporating there, based on what Peter just said around talking to patients, the way we might have those conversations, the picking the right moment? And I love that idea of that collective safety piece. It comes back to that psychological safe place bit. But how do you see the human factors thing changing, Eva?
You're asking me the hard question. We actually haven't started to put a shape on that. I think because we're waiting to hear what is going to be the, you know, the guidelines for opening in September, and you know, what kind of space restrictions will we have to have, and what can we achieve within that. I think we're lucky that we have a 60-hour online professionalism module already done and ready to go, and so we may be using that and making use of that. I think it's definitely not the case that you can just simply transplant the kind of training that we run, you know, onto an online platform, because online platforms are they're really set up for didactic lectures. You know, that is their strength. You can have breakout rooms, you can have discussion groups, you can do skills rehearsal. And I'm in touch with, you know, international colleagues who are, you know, experimenting with all that at the moment. But I think for doctors who are out working in the hospitals, we're going to bring them online. We're going to have to be sure that what we bring them online to do is stimulating, interesting. You know, it's taken a long time to win over the trainees in terms of their attitude to this type of training. And I know, some of them are getting in touch with me and wanting to look at, stress during COVID and things like that. And they're writing papers with me. And so I know that there's they are bought into it at the moment, and I don't want to undo that. So I don't want to bring them online and have them having to participate in, boring, unendless presentations. So we're going to have to be creative.
Absolutely, as we all are in every aspect of our day-to-day lives, and that's interesting. You talked about the models of leadership, and you showed us the pictures there of President Obama and President Trump, and we won't get into that conversation right now. It's not the airways for that. But here's maybe a twist on that one. I mean, you guys have seen a lot of leadership models, and you lecture on it, and you teach people what the attributes and so on might be. What are the leadership models that we shouldn't be going for? What should we avoid here right now in the way we approach this?
So what you don't want is a very authoritarian leadership model, somebody who tells people what to do. What we're after here is the whole idea of authentic leadership. So, where a leader feels like a human being, to others. This idea of, the mastery model, as I said, but somebody who is self-aware, somebody who's in tune with their own emotions, who knows about them, who knows about others' emotions, who can take all that into account. Some people might like to think that you don't need emotions to make decisions. We know that's totally not true. That actually, if you don't have any emotional functioning going on in your brain, you don't know what decision to make. So emotions are decisions are a combination of emotions and logic. So I think it's about authentic leadership ultimately, with flexibility and acknowledging that we're all in the same boat here. We don't know the future. It's not a given.
And I'm going to come to the last question, and it's sort of a biggie, as they say, maybe. But with Peter and both of you can contribute here. We used to refer to the health system in Ireland as a toxic environment to work. You'd heard it reported a lot, did medical council reports, and you name it, newspaper articles, our own conversations on it, that it was a toxic place to work. And that was a factor of all the things you mentioned there: workload autonomy, the loss of autonomy, of course, the lack of reward or recognition, and all the factors that we probably could look at. But here we have something that says it's all going to change. We have an opportunity within a crisis. So what is it that to not have a toxic environment? What is it that you think would be a big priority? If you were sitting in front of Paul Reid right now, Paul, what is it we want the HSE to do? Just 2 or 3 things to maybe not go back to where we were before.
Well, maybe if I went first, I think listen to people would be the first thing that I would say. Nobody knows the problem better than people on the ground. So if you have issues, you need to be listened to, both at local management level and at a more global HSE level. I know that from my own experience during my working times, I never once went to management with a problem and said, what do you think the answer is? And they gave me the absolute answer I was looking for. I preferred to go and say, here's the problem. This is what I think we can do with this. And this is why I think we should go with this. And they invariably would go with it. So I think you've got to bring solutions to the table. There's no point in saying this is a toxic environment. Nothing can work. This is terrible. I want my old job back. So I think we've tried to say tonight that from both a logistical point of view and a psychological point of view, that's unhealthy. So you're going to have to think outside the box. You're going to have to say, okay, I've got so many people on my waiting list. How do I get through these? What's the best way of doing this? Do I interview them all by telephone, by video? Do I pare it down that way? Who do I need to do? What's my absolute list? How many can I get done? Where can I do that safely? And then go to management and say, okay, are we going to have a COVID hospital and a non-COVID hospital? Can I selectively bring in people here under these probable guidelines? Cocoon for 2 weeks, swab, and so on. That's how I'm going to get my work done. And sometimes when we stop just saying this is awful and try and focus on what we can do next week, it gives people a sense of purpose. And then once you start to shift that unshiftable object, suddenly you think, well, I'm getting someplace. And then by that nature, things will evolve. And once, as I said, people start to look around at one another and see, well, in Limerick they're doing this, or in Cork they're doing that. That's how ideas gain momentum. And I think that a good model will come locally. There's no one size that's going to fit the whole country.
Absolutely. And Eva, do you want to say anything?
Well, I'm just going to add one thing. It doesn't come, I mean, I think that's a huge question that you're asking, Kieran, but I suppose the one thing that has been so impressive is the amount of money that the HSE have thrown at the COVID outbreak. You know, they've opened up beds, haven't they? They've been shut for years. You know, they spent a fortune on PPE. They've they put out the private hospitals, which some people might not have different views on, and I think to go back on all that now would I'm not talking about the private hospitals issue now, that's another thing, but to kind of start being really restrictive from a financial point of view, I think that would, putting that very simply, that would just be unfair. And I think the real challenge is how can they get a balance now between maintaining their budgets and not undoing, some of the resources that they have put in place.
Fabulous. Look, I think you're right there. I think you've nailed on the head. Give a lot more autonomy to the people on the front line who do the job. Trust that they're always going to do their best for their patients. I think if you listen to them and let them focus on solutions and support them, we're there. And also recognise the value of our health system to every part of Irish society and just actually resource it and fund it. You can see without the health of the nation, there ain't no economy. And so it's actually, they're intrinsically linked, and I guess we support there. If those two things could get cracking, I think we're in a good shape. So look, I'm going to bring tonight's proceedings to a close. I want to thank both our speakers and for the interesting conversation they had with each other, and I hope everyone was able to join in and listen something about that. So thanks to Peter Gillen and to Eva Doherty. Thank you both for that. And as always, I'm going to give the last word with the President, just to say a few words and maybe a reflection on what we've been listening to for the last 45 minutes or so, and then we bring it to a close. So Ken, over to you.
Thanks, Kieran, and thanks, Peter and Eva, for that really fascinating conversation. A few things struck me quite strongly when you were talking about solutions and what the future holds and what the new normal is. And it really strikes me that as a college, we will lose an opportunity here if we don't try and use this crisis as a means to improve our engagement with our fellows and members. Many of us have found that this crisis has given us new tools. So this webinar, Surgical Affairs wouldn't have dreamt of having a webinar a year ago, and we've engaged with our fellows and members more in the last 8 weeks than we probably have done in the last 5 years. So, and this is something that I think we need to bring with us. But on a more personal note, even talking about, the psychological safety, how we build teams, calling out bad behavior. And we all know what bad behavior looks like. And we all know the individuals that engage in bad behavior. Now is the opportunity, because we actually have the time to actually deal with some of these things. And if we don't deal with these things, we will have wasted an opportunity. So despite the doom and gloom and the negativity and the pessimism, I'm actually enthused for the future, because I think there's a great opportunity for us to do a lot of things better. Two groups were mentioned tonight. One, the trainees, and I think our trainees have been remarkably patient. They're in an extremely frustrating set of circumstances. What I would say to them is, they won't be individually disadvantaged in the short term. They're all in this, they're in the same situation together. JCST and JCI understand exactly what's going on. And if we have to make adjustments to the training program in the short term to get progression from year 1 to year 2 to year 3 and so forth, That won't be an issue. Allowances will be made in terms of sitting exams and timescales. So that will come down the road. And I would also put that the new curriculum is going to be competency-based, not based on actual numbers in logbooks and so forth. So that will deal with some of the issues and adjust for some of the issues and the strains that they are experiencing now. And I would acknowledge and thank them for their patience, because they are being extremely patient. The other group that was mentioned tonight are the private sector. And as I've said before, and I'll stress again, I understand the frustration. That they're in an impossible situation, and I think all of us, both in the public and the private sector, would see that this is very unfair. And while RCSI as a professional body has no intention of getting into the space of HR issues and contracts for individual consultants, because there are unions that can and will do that, we have used numerous opportunities at a high level with the HSE and with the Department of Health to stress the fact that for the private sector, the private sector consultants and the private hospitals need to be actively engaged so that they can be part of the solution here, or at least relinquish that contract and allow them get back to the previous working conditions. So I do feel strongly about those two groups. The college is a fellowship of all members and fellows, not those just in the public sector, but also those in the private sector. And I have had conversations with quite a number of the surgeons in the private sector, and I have stressed the points that I've just made now. So I thank Peter and Eva. I thank all of you for listening. I thought tonight in some ways was empowering. There are ways in which we can survive this process, and I think there are ways in which we should, as a training body, come out of this process stronger. And if we don't, well, then we have personally failed as a college. So thanks, everybody. Thanks, Kieran, again, as always, for chairing this so well. And I look forward to next week.
Great. Thanks, Ken. Thanks a million. So just thank everybody for tuning in. Thank all our speakers. We have made some references to a number of documents, and you heard Eva and Peter talk about some of their great work, which are video based and courses. We'll be making all those available to you, so we'll post them up on the website later on for all the various links there, which are very, very useful for everybody. So just to wish everybody a very, very good evening. It's absolutely gorgeous out there. I hope you get a couple of hours, go for a walk or whatever, and we'll talk to everybody next week. All the best. Bye.
Bye.